My name is Yazan, one of the academic general surgeons at Leeds University. Thanks very much for inviting me to talk to you today. I'm going to talk to you about my existing research, a project that I'm working on towards a PhD degree. Can I start by asking, are there any surgeons in here at all? At all?
Way away from that.
Yes, I would say what I want, but unfortunately they're the one.
Why did you ask the question?
I could say what I want about surgery, but I can't. So we have some,
I mean, are you physicianist?
sorry, I didn't.
Physicianist.
You're using up this time.
Okay, so I'll start by giving you a brief background about the topic, about colorectal cancer. As you all know, colorectal cancer is fairly common. It affects patients towards the middle or late towards their lives. And the peak incidence is between 70 and 80 age groups. Patients who have colorectal cancer generally are considered as frail, and they are at high risk of developing complications from surgery. The latest figure reported from Cancer Research UK is that 30% of patients, around 1 in 3, will develop a complication after colorectal cancer surgery, and the risk of death after an operation is around 5%. But we expect these statistics to be increased in the next 10 to 20 years, simply because the population demographic is changing. People are getting older, and as they get older, the incidence of the disease increases, and we expect to see more colorectal cancer in the next 20 years. The surgery that we perform for colorectal cancer is very traditional. It's 100 years old. The principle of colorectal cancer resection is to remove part of the colon based on the part that's been affected with the tumour, but alongside the colon we also remove a big amount of the vasculature, and we also remove a lot of lymph nodes that's surrounding the colon. So it's a very, very radical surgery for colorectal cancer. But this old traditional operation is challenged. It's challenged by many factors. One is that there's a shift in population demographic. We're facing a lot more older patients who are frail, who can't tolerate these radical surgeries, and they're more likely to develop complications and die, unfortunately. But we also noticed that since we introduced a national bowel screening program, we're picking up colorectal cancer fairly earlier. So there's less number of patients who have colorectal cancer with lymph node metastases, and therefore we don't think these patients will benefit from a radical surgery compared to someone who's got lymph node metastases. So the old surgery that we have to stop and think and see whether we can actually stratify the surgery that we offer to our patients. So ultimately, based on the facts that I've mentioned, we're trying to develop a stratified approach to surgery tailored to individualized needs. At the moment, we rely on imaging, including CT scan, MRI scan, but CT is the most commonly used nowadays in the NHS. But unfortunately, the sensitivity and specificity of CT for detecting lymph nodes is around 50%. It's like tossing a coin. So here we try to develop a solution for this problem, and fluorescence-guided surgery. Fluorescence-guided surgery has been in practice, not in clinical practice, but in research for the last 10 to 15 years. And fluorescence-guided surgery tries to help surgeons to identify local metastases within the lymph nodes intraoperatively, so we can stratify patients into radical surgery versus localized or less radical surgery. This image was taken from a recent trial done in Leeds. It's called the GLISTEN trial. So they inject the patients with a fluorescent molecule, and then they shine the light intraoperatively, and as you can see here, this fluorescent is a metastatic lymph node within the mesentery of the colon. However, patients developed a lot of toxicity and had to stop the trial. So the drug that was given to the patients was very toxic, so they couldn't carry on with the trial. Recent research has found that nanoparticles or nanotechnology could be the alternative to drugs. And most importantly, silica nanoparticles, which are very, very small things, 1,000 times smaller than the tip of a human hair, can be injected into humans without eliciting any immune reaction, and can be used as vehicles to deliver treatment. It can be used as vehicles to tag fluorescent molecules on them, and they can fluoresce nicely intraoperatively. So the aims of my research was to manufacture and functionalize silicon nanoparticle that can specifically target colorectal cancer cells and see if that could work in colorectal cell lines in animals. So I'm going to take you through the steps that I did to manufacture my silicon nanoparticles. Essentially, I've manufactured the silicon nanoparticles, as you can see them on the right in this graph. This is 10,000 magnification of these silicon nanoparticles. Inside the silicon nanoparticles there's a dye, and this dye gives the nanoparticle, as you can see, this fluorescent colour in the line. Now, we've measured the size of these silicon nanoparticles, and the average size is around 50 nanometer, so they're very, very small, particles. We also checked their emission and absorption wavelengths, and we wanted to make sure that we have the tools and the means to detect their fluorescence. So they emit their light at 696 nanometer, which is something that we can absorb and visualize with our microscopes. Now, then I had to go on and decide how am I going to conjugate or link this silicon nanoparticle to target the colorectal cell lines, and the best way is to use an antibody against CEA. And CEA is a cancer-specific marker for colorectal cancer. And recent papers published suggested that CEA is the most specific colorectal cancer marker. So we've used CEA antibodies, but when we tried to link antibodies to the nanoparticle, that completely failed. So we had to find an alternative, and the alternative was to find what we call a chemical linker. It's called PAM dendrimer, and as you can see, it's a complex chemical linker. But what's specific about it, it has a lot of amine-free groups, and these amine groups can link to multiple antibodies, but equally can link to the silicon nanoparticle stably and comfortably, and that's how I manufactured my nanoparticle. So this is the end result of my nanoparticle. So the core, there's a dye that's fluorescent, and outside it is a silica shell, so that's why we call it silicon nanoparticle. And then outside the silica shell, there's what we call a functional plus linker, which is the PAM dendrimer, the chemical linker, and on top of that is an antibody that will target the colorectal cancer cell lines. So after I've developed my nanoparticle, I had to test it in vitro in a series of colorectal cancer cell lines. So LS174T, LOVO, and HCT, these are malignant colorectal cancer cell lines, and HEC is a benign human kidney cell line. And as you can see, I've incubated the silicon nanoparticle with the colorectal cell lines for 24 hours. Then I imaged the cells under what we call a confocal microscope, which is a specialized microscope. And as you can see, there is significant difference in terms of fluorescence between colorectal cell lines across 3 colorectal cell lines and the benign, so there's no signal at all on the benign. But equally, to verify my results, I had to use a control antibody to make sure that these silica are not sticky to any cells. So the control antibody that I've used was a normal anti-digoxin antibody. And as you can see here, there's absolutely no signal, non-significant signal, insignificant signal equally. And the fluorescence that we got from the tumour cell lines was actually quantified, and there's statistical significant difference between the NCA antibody tagged silicon nanoparticle versus control antibodies. Then after we thought it was successful in vitro, we had to test it in animal models. So we used a well-established animal model at the University of Leeds, where we inject the mice with tumour cells into the right flank with a colorectal cell line of LS1714 xenograft. And then after we leave it for 6 weeks, we injected the tail with the silicon nanoparticle that contains the antibody. And here's the results. So this is a mice that was treated with the silicon nanoparticle. This is after 6 hours of injection. There was no localization to the tumour. Within 24 hours, there was no localization to the tumour. At 24 hours, we start picking up the signal, and equally at 48 hours, we start picking up the signal straight at the colorectal cancer cell line. I've had an image. I've also done an image on a control mice, but I didn't put it on the presentation today, I'm afraid, sorry. But I can tell you, silicon nanoparticle with NCA antibody specifically targeted the colorectal cell lines, and it didn't elicit any immune reaction in the mice that I've tested it on. I've only done 2 mice, but I need to do more to confirm these results. So, just to summarise what I've presented, the silicon nanoparticle with NCA antibody allows us to specifically image and target colorectal cancer, whether in vitro and in vivo. These silicon nanoparticles have the potential to be translated into clinical practice in the future for intraoperative visualization of tumour cells and help with fluorescent guided surgery. And to date, this is the first targeted silicon nanoparticle against colorectal cancer. There are loads of silicon nanoparticles that were attempted against colorectal cancer, but this is the first one that's got well-controlled specific antibody against colorectal cancer. So where we go from here, the next step is, as I said, I need to increase the number of animal models to get reasonable conclusion. But the antibody that we've used against CEA, although it's very specific, but antibody is very expensive and would be difficult and prohibitive to use in clinical practice because it would be too expensive for fluorescent guided surgery. However, at the University of Leeds, they have developed what's called a synthetic antibody called Adheron, which is very, very cheap and can be produced at cost-effective levels. So we'll try to replace the antibody with an Adheron, but also we'll try to functionalize the silicon nanoparticle. We can tag a photosensitizer to the nanoparticle and a contrast agent to the same nanoparticle, so that will give us a multifunctional silicon nanoparticle that's specifically targeting colorectal cancer. That will offer the surgeons preoperative MRI images, intraoperative fluorescence, and in addition, what we call photodynamic therapy based on the photosensitizers delivered. So you'll be free functional within one silicon nanoparticle. Finally, I would like to thank my supervisors and the team that helped me develop this, and welcome any questions from the floor. Thanks for listening.
For each of these presentations, we have about three minutes or maybe 4 minutes for questions, if there are any. So thank you so much. And do we have any questions? Well, before we do, actually, can you explain to me, as a, I'm a psychiatrist, so I don't really when you come to operate, you actually see the bits you want to take out lit up.
That's right.
How does it work in practice?
So essentially, the silicon nanoparticle can only be used laparoscopically. It's not suitable for open surgery because the fluorescent...
Yeah. It's in the dark.
Exactly.
Yeah.
Laparoscopic, the surgery of colorectal cancer has transformed massively over the last 20 years. Most
Yeah.
of the colorectal cancer resections are
Well, that's when I was a medical student. It was
Yeah.
way before that.
They're performed laparoscopically nowadays.
Yes.
So the very small
Wow.
proportion that get done as an open procedure.
Yeah.
So that will actually enhance the use of laparoscopic surgery. I will encourage more surgeons to use laparoscopic surgery for colorectal cancer resections.
So you use a special light when you go in that lights it up. Then.
That's right, yeah.
Yeah.
It's got a specific wavelength that would meet the fluorescence of the nanoparticle that would emit the light.
Fascinating. Any questions?
Yes, sir.
45 years ago, CEA was the sort of mecca, the elixir for colorectal surgery. It was going to show us what to do, and now here it is. It looks as though it might. What about the therapeutic implications of linking nanoparticles to therapeutic agents that might have colorectal cancer cells?
That's a very good question. I mean, this nanoparticle technology itself, it offers you a multifunctional nanoparticle. You can virtually conjugate anything into the nanoparticle if you can know how to do the chemistry. So people have used chemotherapeutic agent, they tagged into nanoparticle and they delivered systemically. Others used MRI contrast agents. People have used PDT or photodynamic therapy. But we don't think that colorectal cancer can be cured with a chemotherapeutic agent. But we're using this to help surgeons stratify the surgical approach to patients. But our plan is to conjugate a photosensitizer that will be able to deliver a photodynamic therapy. So after you've resected the tumour, you can mop out the bed floor and remove any residual cells that we think will be left behind after resected the tumour.
Yes, Andrew?
That was really interesting. Now, a surgeon's going in laparoscopically, he or she needs a roadmap. But your technique, as I understand it, does not provide that roadmap beforehand. You need to be able to go in and apply the light to look at that fluorescence image. So, what consideration have you made to produce a roadmap that is available before the first cut is made?
Okay, so as I said, the next step of the project is to conjugate the MR contrast agent. So hopefully, once you're given the MR contrast agent, sorry, the nanoparticle with the MR contrast agent, you'll be scanning the patient before you go to theatre. And after they've had the scan, they go into theatre, the surgeon goes in and they can correlate preoperative images with the intraoperative findings, and then they can shine the light.
So in terms of the chemistry that's required, you need the antibody to CEA and you need the MR contrast agent to be linked.
That's
So
right.
what is the feasibility of that tagging?
That's very feasible, simply because the nanoparticle shell has got the dendrimer. It's got multiple amine groups. These amine groups provide active functional arms. It's like 100 arms on each nanoparticle. On each arm you can conjugate 5 or 6 antibodies, or you can conjugate 50 gadolinium contrast agents, and probably 40 photosensitizers. You can actually control the percentage of each molecule that you have on each nanoparticle.
Wow. Any more questions?
Is there a risk that if you have all these kind of hydrophilic or whatever they are bonds on the molecule that is attaching, you can get macromolecule formulation and you actually cease to get a nanoparticle and you end up with a bloody great piece of stuff going around and actually clogging up one or two vessels?
Yeah, that's a very good question. So far, from all the nanoparticle work that has been done before in humans, there have been no reports at all on PEs or coagulopathies at all. We haven't done any studies on humans yet. All my studies are on animals. I can't answer that question. But searching through the literature, all appears to be safe so far. Having said that, we are the first people to use targeted therapy with antibody. If anything, I think that will actually enhance targeting the nanoparticles into the colorectal cancer and preventing this from being in circulation for prolonged periods.
And the brother. Sorry, guys. I hope it's a good one.
But the CEA, does all the colorectal cancers produce CEA?
Good question.
That's a googly.
I don't understand the
That's a
question.
googly question.
So no, the answer to that is no.
No.
But most of the colorectal cancers are adenocarcinomas, and most of the adenocarcinomas do produce CEA, but in different concentration, different percentages. But my work is to follow on from a previous PhD student who actually studied the colorectal cancer markers in depth, and he found CEA was the best available marker for colorectal cancer. It's not ideal, it's not perfect, but it's the best available.
I think we've only got time for one more question, if that. Can I just ask one thing?
One more question which you're going to ask.
You say we, and you're part of a team doing this research.
So all the work that I presented was
Yeah.
done by myself.
Wow. Yeah.
But I was obviously working in a group lab. So I had my training, but I've performed all the work that I presented so far.
Okay.
So
Cool.
it's teamwork.
Fantastic. Thank you very much. Our next presentation tonight is Daniel Jones. No, sorry, it's not Daniel Jones.
Yeah.
I've got the wrong list. Don't panic. It's Anna Winfield. That's the list of the markings, sorry. Oh, right, sorry.
Oh.
Thank you for inviting us to come and present. My name's Anna, and this is my colleague Sophia, who's a third-year medical student, and she's going to introduce our project.
So hi, we're speaking about a quality improvement project that we've got some technical issues today. I don't know what we're doing. There we are. Right, so we're speaking about it.
It's a mouse, electric mouse.
I know you brought it alive, clearly. So we're talking about a quality improvement project that we established as part of a team, and the title is Working Across Boundaries to Detect and Intervene in Frail Patients at Risk of Falls. So we're just going to talk a little bit about the aims of the project, the background, our interventions, the results, the next steps to our project, and the conclusion. So our project aims were to establish over a 12-month period quality improvement projects that provides comprehensive geriatric assessment to moderately frail patients in a GP practice, and to improve detection and management of moderately frail patients in order to reduce falls. So Anna's just going to talk a little bit about the background and hopefully it'll make a bit more sense.
So there's overwhelming evidence that frailty and falls are linked. And we know that sadly 50% of people over the age of 80 will fall at least once a year. And falls sadly are a major cause of mortality resulting from injury in those over 75. But not only can people sadly die, but they experience significant comorbidities such as fractures, hypothermia, pressure-related injuries. So it's a big problem, and our project was performed in Leeds. And if you look at Leeds teaching hospitals, they have 686 hip fractures a year, which is about 13 a week. And as you can see from this graph, the number doesn't really fluctuate. There's not a huge amount of variability. So we know that there's significant mortality and morbidity associated with falls and fractures. but people often forget the psychological consequences of this problem. And we, as part of our project, we spoke to patients who were inpatients at Leeds Teaching Hospitals who'd had a fractured hip. And we were quite shocked that the biggest problem that they reported, or that their biggest worry, was not necessarily the ins and outs of their hip fracture, but it was actually the fact that they didn't want to become a burden to their family, that they were really worried about falling in the future, that they were frightened about being at home by themselves, lying on the floor, and nobody would come and find them. And these were people who had lived independent lives. This lady, who actually isn't a patient, it's just an image, and obviously it's been changed for confidentiality. One particular lady was a very chatty, independent lady, used to go out all the time, very intelligent, but sadly, due to her falls and her previous hip fracture, she was unable to do that. So we've talked about the psychological consequences and the physical consequences, but there's also financial consequences. And we know that approximately the average cost of a hip fracture is over £10,000. And this doesn't take into account any of the psychological consequences. This is just actually treating a hip fracture. So what can we do? Well, the evidence tells us that the gold standard treatment for frailty and falls is a comprehensive geriatric assessment, and this leads on to producing a multifactorial falls assessment and then an individualised intervention to try and prevent falls and reduce frailty. So in order to establish our project, we used the evidence that we gathered and our expert knowledge on falls, in inverted commas, to establish areas that we considered clinical variation. So people asking patients, have they had previous falls, medication reviews, treatment for osteoporosis, and referral on to the falls service. So research performed by the University of Bradford have basically developed something called the Electronic Frailty Index, which uses the patient's comorbidities to give them a score of how frail they are. And we looked at patients with an electronic frailty index of 0.25. So these are people who have moderate frailty, difficulty with outdoor activities, sometimes have problems with activities of daily living. And this was our cohort to try and focus an intervention to try and improve their general health and well-being.
Okay, so I'll now introduce about where we sort of established our project and where all the fieldwork took place. So this is Alton Medical Surgery, it's a GP practice, and we identified 97 patient records with an electronic frailty index of 0.25, and we extracted these from System 1, and all of the patients were aged over 65, and just for reference, the mean patient age was about 77. Okay, so just to talk about the medication results. So this is a table that we use to extract the medication, the medications from the patient records. And the mean number of medications per patient was 10, so ranging from about 3 to all the way up to 24. We can see some people being alerted by that. 28% were on an opioid. 87% were prescribed an antihypertensive, and about 100% were at least on one medication that could contribute to falls, and no patients had a lying or standing blood pressure recorded. So I mean, they're shaking heads, and we thought exactly the same. It really emphasised to us why getting these patients in to our workshop was really key, and how we managed to identify these patients. Really just to try and get some improvements. So this is just to take a look at, just a closer look at the comorbidities. So again, this is our extraction table. And some of the things we just like to point out on here is that 23% had a fall documented in their notes within the last 2 years. 27% had a fracture aged over 50, aged over 50 and above. One had 6 falls within 2 years, that was one patient, and about 33%, so about a third of them, used A&E within the last 12 months. So we really thought we could, with this project, reduce hip fractures, falls, and A&E admissions, and there was really some room for improvement that could be done around this. So what we did afterwards, we decided to telephone screen them first. So 97 patients. We managed to get hold of 60. So the dropout rate with this really was that some of them weren't appropriate. You know, some patients had things like Alzheimer's disease and they felt that they didn't want to speak to us over the phone. Some patients were unfortunately poorly at the time. Some had unfortunately died, and some obviously declined to participate in the study. So we got hold of 60 patients, and a bit of learning for us was that we created this falls questionnaire, and we used to use all 10 questions, but after a while we did these telephone screening. It took quite a while to ask all these 10 questions. So we used questions 1, 2, 4 and 6, and any answer, if patients answered yes to any of those questions, they would be invited to our workshop if they wanted to. So one of the things we really thought we'd highlight here was that 65% had fallen or stumbled in the last 12 months, but only 22% or 22 patients had a fall documented in their records. So we thought, wow, you know, to rely on this documentation, just the medical records, without having to call up the patients, we're getting massive differences, about 45% difference or 40% difference in what we found as a result. So we then invited them to a multifactorial falls assessment. So really sorry if this is a bit small, but what we did was we weighed the patient, we asked them about their medication, we did a bit of a memory check on them, a depression screen, an osteoporosis risk, and of course their lying and standing blood pressure, because we found that no one had one. So one of the things to note is that 51 patients were screened via this workshop. So from 60 patients that we telephoned, 51 were assessed as a high risk, which we thought was quite high too. And 27% had a significant lying or standing blood pressure drop, and 90% required implementation of interventions, and the most common one was 77% needed medication changes. So we used a method called co-production, which we decided to get the patient feedback, and we decided to reflect how well we thought we did in the workshops. So just to try and improve the way that we run the workshops, and just to get as much patient feedback from the patients. So 92% found it very useful, and all patients said they would be happy to come back to a clinic in the future. And just anecdotally, you know, some of the patients reported, like, we're so happy that, you know, we're being listened to, because sometimes this 10-minute consultation is so tricky to talk about so many things. And they thought they had like a really good thorough review after this multifactorial risk assessment.
So from our project, what can we learn and what can we disseminate to other GP practices? So as Sophia has talked through, we've developed this flowchart or proposal basically that other people can use to put into practice what we've done. So essentially what needs to happen is a patient cohort is selected, so those who are moderately at risk of falls are found using the electronic frailty index. You telephone them to determine their individual falls risk based on the answer to those 4 questions we talked through, which are listed on the flowchart. And those patients who are determined as high risk based on these evidence-based questions are invited to the falls workshop, where they experience a multifactorial falls risk assessment, and they also have a medication review, and then the GP can consolidate this information to produce an individualised action plan. And actually, most of this can actually be done by a healthcare assistant, and the resulting time spent by a GP is actually very minimal. And as I discussed at the beginning of the presentation, the cost of falls is huge to society, not only in terms of morbidity and mortality, but also the psychological consequences. That this process, when costed, only costs about £47 per patient. So we also received some good news since we submitted this project, in that we presented it to the CCGs in Leeds, and 9 GP practices have decided to take on our proposal. So hopefully that this will be exposed to 70,000 patients. So in conclusion, our proposal has the potential for improving the population's health, reducing morbidity and mortality, and certainly A&E admissions. We know for a fact that it improves patient experience. It certainly has really good cost implications. But one of the things that we want to focus on is the fact that it's proactive care rather than reactive care, which is, I think, where the future's headed. So thank you very much for listening to us.
I was going to ask a question about who would apply the workshop, and this, you've answered that question. So that's great. Any questions on? Right, we've got two at the back. Start with. Yeah.
Did you consider the vision in any of your patients, whether cataracts or whether the glasses were?
Yes, we did as well. Yeah, so we asked a few things. We kind of skipped through that. So we asked about alcohol intake, and visual problems. That was another of the things. Weighed them, did a Frax risk assessment, lying and standing blood pressure. Also just simply palpated their pulse, and we found some patients who were really bradycardic, and some which were on beta blockers, some needed an ECG, and to check they weren't in an
Well, I
arrhythmia.
just know getting older that my vision.
We didn't do a specific visual assessment, but we did ask if they had medical problems.
Would you like an invitation to attend? And there's just behind you.
Plainly, with the implications, you should patent this because there would be revenue in. I'm fascinated that this should work because I've been a specialist in falling ever since I was born. I tried to stand up, and I'm always falling. Yet if you rang me up and said, "Do you fall over sometimes?" I'd say, "Of course not." How is it that there's a common language that divides us or unites us, depending on which perspective you have of it, can work so well when you haven't even defined falls? I mean, have you ever fallen over yourself?
So you've answered the question.
We asked patients as well because I think quite a lot of people, when you said, "Have you fallen?" Sorry, and they said, "Oh no," and said, "Oh, or stumbled," and say, "Oh well, actually, yeah, I stumbled over." And so people kind of use different language, don't they, to express.
Yes, I know I've never fallen, but the ground has come up to me. Well, on a couple of occasions in the past. Oh, Jessica, I think.
Oh yeah, sorry. I just wondered how long it took when you did your workshops. How long it took for each patient?
So, yeah, really good question there. So I think we had the patient in and we allocated half an hour in total for the workshop, for the multifactorial risk assessment, and then to see the GP. So the lying and standing blood pressure just on its own takes 10 minutes. And what we used to do is we used to sort of weigh the patient, get them comfortable, introduce them, but then we would say, is it okay if we lie you down, are you comfortable lying down, and we're doing the lying standing blood pressure, and is it okay if we ask you the questions while you're lying down? And most of them agreed to say yes, and most of them were quite comfortable just as staying lying down, and they thought it was actually quite a good chilled out experience. So they were just sort of quite happy lying down, and then so that would probably take about 15 minutes, and then we would take them onto the GP room, which sort of give or take again 10 or 15 minutes depending on the amount of interventions I think.
That bit was kind of the shortest bit of time. The bit that's being demonstrated with the lying and standing blood pressure and the actual fall assessment took a while, but which can be done by a healthcare assistant, thankfully, and then the actual GP involvement as well.
Yes, Catherine.
So, can you tell me how many of the patients had atrial fibrillation and how many might have been on an anticoagulant?
So I can't give you the figure off the top of my head.
Do you have any idea of how many you would expect?
So in terms, sort of roughly speaking, I think I would say about 15% had AF. We did find one patient who had told us that they had frequent falls and was on warfarin, and we had to we discussed with them sort of alternatives and risk benefits and things. But I can't remember off the top of my head how many had AF. I think it was probably about 15% roughly.
So that's higher than you would expect from that population, a bit higher.
And we possibly diagnosed somebody as well.
Yeah.
Yes.
Because the proof of the pudding in a way is in the eating. Do you have plans to follow up and see whether there is actually an effect on subsequent incidents and A&E attendances, fractures?
So we're really happy that our project's going to be done on higher numbers, so we can actually make some real firm conclusions. So we're going to monitor what happens with these 70,000 patients, and they're going to use our data collection tool, and then we'll be able to use System 1 to sort of track down what's happened to them. We obviously can't do that by ourselves, but we've used like some of our one of our colleagues who's a GP, and we have a pharmacist in our team as well, so hopefully we'll be able to team up to do that.
John?
What was the commonest group of drugs you stopped? Was it beta blockers, the other opioids, or what?
It was mainly antihypertensives, like Ramipril, for example, and bisoprolol was again really quite common because quite a lot of people were bradycardic and had a postural drop. So I think that was probably the most common. But there was also quite a lot of people who were on tramadol and things as well, which we needed to stop.
One of the things that really does help people who are unsteady on their feet, tend to stumble and so on, is a referral to the balance clinic. Is there any, did you discuss with the CCG having a more developed balance clinic that you could refer some of these people to, because building up their muscle power and just their confidence in moving reduces their risk of fall?
Yeah, that's a really good point. In Leeds we have a falls clinic which can sort of tap people into like balance training and specialist physiotherapy for balance. The physio who's linked to the falls clinic is really sort of like highly skilled in that area. And I think, I can't remember the exact percentage, was it about 9% we had to refer onto the hospital falls clinic because they had more complex things that we couldn't really deal with in general practice. It wasn't as simple as just stopping a medication, but they needed some intensive physio to help with their balance and things, and exercise training.
Thank you. I think this is a very pressing question. No, I think we're going to have to end it there. Well, thank you so much. Our next presentation tonight, I'll get this right this time, is Daniel Jones.
So, thanks for asking me to come and speak, or picking me to speak again. My talk's on digital rectal examination to diagnose prostate cancer in symptomatic patients in primary care. I've written my team on, so I had the pleasure of supervising 2 medical students for this. So Charlotte and Andy, a German medical student, came and helped me with the project. Although it was my idea and my sort of finishing off, and then a statistician and Una's my supervisor. So it sounds quite boring, my topic, so I thought I'd tell you a story about Barry, a 70-year-old retired plumber who doesn't really visit the GP very much, just does his 2 loves, which are Hull Kingston Rovers and golf. Barry starts to develop some waterworks problems, hesitancy, frequency, urgency, post-micturition dribble, incontinence, he's got everything. Sexual dysfunction and nocturia. His wife books him an appointment with a GP. Barry doesn't really want to go, so he meets some of his friends to ask them what it will involve. The first chap says that, well, they pick the guy and he checks your prostate. The second man says that it's really painful. And the third man said that when he had it done, he was quite embarrassed. So now Barry's worried and he Googles prostate exam and he finds this.
Do you get that picture?
So Barry makes a decision, he makes a choice, and he decides to play golf rather than sit in this waiting room. Sadly, it gets worse for Barry. He develops hematuria and back pain, and when he does decide to go to the GP, he does get the examination and a blood test. He's urgently referred to the hospital. He's diagnosed with prostate cancer, and sadly he's got bony mets, so he has to have palliative care. This got the GP thinking. He heard Barry's story, he heard all Barry's worried about the prostate cancer and the rectal examination, and do we really need to do the rectal examination? Is it worth doing? Can we just reassure patients that we won't check their back passage, we'll just get them in, and if they've got symptoms, give them a blood test and they'll go away? to the hospital. So now that I've made it a bit more interesting, hopefully, I'll tell you about prostate cancer. So it's the most common cancer in men. We had 41,000 cases diagnosed in 2011, and there's a 1 in 8 chance of developing it in a man's lifetime. So 41,000 cases is the size of Ellen Road. Not that we ever get 41,000.
Fighting talk.
And then the next question is it worth diagnosing prostate cancer early? Are there more harms than benefits of diagnosing prostate cancer early? Do people live with it rather than live without it? Rather than die with it rather than of it? Most of those questions come from the screening debate, however. Should we use PSA to screen for prostate cancer? There seems little point in delaying the diagnosis once patients have got symptoms. So the next point is that 1 year survival, based by stage of diagnosis, drops dramatically at stage 4. So people diagnosed much later with later stage disease have a greater mortality. In the UK, we have a prostate cancer risk management programme where patients can come and ask for a screening test if they want, but most people are diagnosed with prostate cancer when they come to the GP with symptoms suspicious of prostate cancer. So we've just got some new nice guidelines on the recognition and referral of cancer in general practice. They say that we should do a prostate-specific antigen test and a rectal examination to assess for prostate cancer in patients with, well, all Barry symptoms. And a new point, if they have a rectal examination that feels malignant to the GP, they should do a 2-week wait referral. When you look at the NICE guidelines, sorry that's not come out very well, but it's very easy to find the evidence, what they've used to make their recommendations. And looking at that last point, the point about the doing a malignant, doing a rectal examination and if it's malignant referring, comes from one study, one case control study done by Willie Hamilton, who did a lot of case control studies called the CAPER series of studies. And if you look at this one study that they've used to recommend it, it looked at 217 prostate cancer patients and 180 age-matched controls, and it found that people with an abnormal feeling prostate examination had a 12% risk of cancer. 2.8% if it was normal. So again, the GP's thinking, well, that's not very good. One study of 217 prostate cancer patients, and Paul Barry's now got metastases because of that. So would we be better not doing that? So my study was to try and find out if there was any more research on the benefit of doing a PR, a rectal examination, in symptomatic patients in primary care, and I did a systematic review. The team of us did it properly. We searched 4 databases and we used a grey literature as well. We registered the topic on Prospero and made a protocol first, and we used search terms around prostate cancer, digital rectal examination, prostate examination, and primary care. So we made this Prisma diagram, very boring diagram, but it's in every systematic review, and I'll just make it bigger. So we found 280 studies, and we got rid of 148 of them just on title and abstract. And then at the bottom half, we looked at 22 full texts and had to get rid of 18 of them because they were either screening, they looked at BPH, they were reviews or guidelines, they weren't in primary care, and they didn't look at DRE. So we were left with just 4, but still better than NICE managed, I suppose. So 4 studies in the meta-analysis, and looking at where they're from. There was 2 from the USA, 1 from the UK and 1 from Spain. Importantly, they all had to have symptoms. They had to have seen a GP or sort of not a specialist that had to do the DRE, and then they had to have some comparison, which was usually biopsy, or in Hamilton's study, because it was retrospective, it was the diagnosis of prostate cancer. They were all elderly men. Well, over 40, it's not elderly. So this is the combined results table, this 2x2 table that we used. Lost marks there. We had 3,225 patients from our 4 studies, and this is a 2x2 table that you can make from that, and then with that you can do these clever statistics, but you can pull the sensitivity and specificity and positive predictive value and find out if it's any good. So these were my results written down. So sensitivity of 28.6%, specificity of 90.6%, positive predictive value of 47.6%. And it's this one that's probably useful to GPs. I'm worried that our first presenter would think these sensitivity and specificity are rubbish, which maybe they are, but it tells us that if a GP feels an abnormal prostate examination, he's got a 47% chance of having a prostate cancer. So we're all right at telling, really, and it is worth doing. What does this mean? Very quickly. In the discussion, we'll know that NICE has just reduced the risk threshold, or just come up with this term, risk threshold, where GPs are supposed to refer people if they've got symptoms that make a risk of over 3%, so very little. So the prostate examination gives them a risk of 47%, so well over that 3% risk threshold that NICE has just made. It's the first study to look at this, review and look at these four things and combine them, and it supports the NICE guidelines that say we should do a rectal examination and we should refer if that feels malignant. So what does it mean for Barry? Just very lastly, it means that he does have to come in for his examination, and what we probably need to do is have more education, so things like the Be Clear on Cancer campaign, and educate Barry that it's not that bad and it's good to get diagnosed early. And there's a few things like that. So that's the end of my presentation.
Right, I'm not going to say how old I am, but I'm older than 40. 40,
Barry.
well, only just 40. Any questions?
So this is really interesting. And there was an adage that if you didn't put your finger in it, you know. Exactly.
Yeah.
So what is the relationship between putting your finger in it, detecting it, and the abnormality? In other words, what are the symptoms that would guide a GP to putting a finger in it?
I suppose we'd have to go on.
Because we know that putting a finger in it is equivalent to tossing a coin.
Yeah.
It's a challenge.
Yeah, that's a good question. I suppose we just have to go on NICE's recommendation of those symptoms.
That doesn't mean it's right.
No. I suppose the Willie Hamilton paper that I didn't show you, looking at the positive predictive values of other symptoms, showed that they on their own had a risk associated with them, and most of them were over the 3% threshold as well. So based on those case control studies, that's where I suppose we do. I thought the question you were going to ask is what determines a malignant prostate and who decides that, and all these papers just used the GP saying it felt malignant as the like qualifier of what is abnormal. But that's something that's not really defined.
So I suppose really the question is, if the symptoms are no good and the GP putting a finger in it is no good either, it's the same as tossing a coin, might he just as well do a PSA on the risk-sensitive population?
This is your second question, Andrew. I'm sorry, we're going to have to move on to another question.
Can you just remind me, so you said the positive predictive value is 47%, so actually I think, as opposed to what we're saying, if the GP feels it's abnormal, that's pretty good,
Yeah.
because it likely is to be abnormal. He then said that if it doesn't feel abnormal, in 87% of people, it won't be abnormal.
Yeah.
But that means that in 13% of people, it will be prostate cancer, which is higher than the 3% threshold.
Yeah.
In that case, it's over, whatever you do, it's going to be over 3%.
Yeah.
So you just refer.
Yeah, I suppose.
Anyway,
Yeah.
exactly.
So it's looking at it the other way around.
Yeah. Yeah, I can see that point as well. So yeah, I think it was 90% the specificity, but that's still over the 3%. You're right.
It
So
is. So if a chap comes in and has symptoms, then
Refer them.
let the urologist sort it out.
That's probably a high percentage of the population, isn't it?
Which is different from what we're talking. other
Yeah.
thing, which is the fact that if you don't have symptoms, don't do a PSA,
Yeah.
because that is screening,
Yeah.
and that hasn't been shown to be a benefit.
Yes, we were just looking at symptomatic population, yeah, which is, I suppose, what's not being done, but I suppose the conclusion is up to debate, isn't it?
Yeah.
There must be a huge economic cost to referring everybody.
Yes, that's the issue.
What men over 60 don't have some of those statistics?
55.
There was going to your point a little, there was a paper by somebody called Meacham who looked at the GP practices and the number of 2-week wait referrals they did and their outcomes for cancer, and the outcome of that paper really was that the more 2-week waits you did, the better your outcomes were for cancer.
What a surprise.
Yes, so regardless of whether they were correct 2-week wait referrals or not, the more you did, the better the outcome. So the conclusion of that was that we should be referring even more people, and I suppose that's why the threshold from NICE has been reduced, but I agree there's a cost to it, isn't
Okay, any final questions, or should we move on to the final topic of tonight? Oh, one more.
With the 4 studies that you found, were you satisfied with the hierarchy of evidence of studies? I missed kind of...
Yeah, so if we go to that tip, I mean, you can't really do a randomised controlled trial on this, so the best we could do is cohort, and we had 3 cohorts in a case control study, and we assessed them for quality using the NICE assessment tool for cohort studies, and they were good quality studies, but I think cohort's the best we're going to get, really.
Well, thank you very much.
Dan,
what?
it's not really a question, it's more of a sort of comment really. We were talking about patients actually dying with prostate cancer rather than of prostate cancer, and that was what I was sort of taught as a medical student not that long ago, as you know, because it was a few years before you. But nowadays, as a GP, I'm seeing lots of patients who actually are dying from prostate cancer. Now, do the figures sort of hold that up, or is it, or is it just anecdotal because you're seeing patients day to day now?
Yeah.
But it seems to be a lot of aggressive prostate cancers.
Yeah, I suppose you just see more of them in the GP practice because they come in more. The studies are showing that the number of prostate cancers are going up in terms of the numbers diagnosed, but survival's increasing as well. So I suppose we're medical school taught, you're still right, even though probably we're just seeing the ones more.
So should we be having, rather than the question whether we should have a PSA test, is whether we have to, obviously, to just go straight for the examination, basically.
Yes, that's the answer.
Yeah.
Thank you very much. Our final presentation of the night is Jessica Pierce.
Okay, hello everybody. We're really grateful for the opportunity to speak to you all tonight in this beautiful building. So thank you very much for having us. My name's Melody, this is Serena and this is Jessica. We're all Academic Foundation Year 2 doctors based at York. So we'll be speaking to you today on our subject, ward rounds, when Foundation Year 1 doctors take the lead. So just briefly then, we'll talk a little bit about the background to the project, why we did it, what did we actually do to gather some results. We'll discuss those results, draw some conclusions, and then there'll be some opportunity for questions at the end. Okay, so how did it all begin? Well, the 3 of us all worked together as Foundation Year 1 doctors, newly qualified doctors, in Scunthorpe General Hospital. And we realised that we were regularly conducting medical ward rounds with no direct supervision from a senior doctor, which as newly qualified doctors was quite daunting. And we wanted to explore really if this was a similar experience that other Foundation Year doctors were having. So we had a chat with Dr. Ian McNeil, who's a postgraduate medical education lead for North Lincolnshire and Goole Hospitals Trust. And Dr. McNeil had done a lot of work in the past looking at ward round checklists. And he's looked at these sort of in comparison to the aviation industry to look at how they could lessen the chance of human error to try and improve what's happening on the wards, and that really they're mainly there as a tool to remind us what we already know, but to just give us that extra prompt. So there is some existing literature out there about ward rounds, and there's a really useful document from the Royal College of Physicians. And just to emphasise, this is really about medical ward rounds. So the RCP said that ward rounds, as you may expect, are really fundamental to inpatient care, but there are aspects that are often forgotten, things such as nutrition, mobility, things that are still really important. And there is evidence out there as well that checklists may help reduce human error. And I'll just make a note at this point as well to say that throughout the presentation we will refer to our work as an aid memoir. And this is because we're aware that checklists can often be a term that people switch off at because there's so many of them around, but the principles still remain. So the aims of our project were to explore Foundation Year 1's experience of delivering ward rounds and to consider interventions to try and improve things both for doctors and for patients. So how did we do this? Well, we created a SurveyMonkey, which is an online survey, and we circulated it to all 45 Foundation Year 1 doctors at our trust. And we spread this via word of mouth, via NHS mail to everyone within the trust that was Foundation Year 1 doctor, and also using a phone messaging device called WhatsApp. And we looked at 4 main things really, and that was the frequency. So we wanted to know how often were people conducting ward rounds as a Foundation Year 1 doctor unsupervised, and did they feel prepared to do this as a freshly graduated doctor, and were they remembering some key aspects or were they forgetting them? And then we also wanted to ask a little bit about some potential interventions as well.
Okay, so I've got the pleasure of talking you through our findings. Out of the 45 F1s in the trust, we got 21 responses, so that's a response rate of 46.7%. The first question, as Melody said, was about their preparedness. So we asked them, we gave them this statement. At the start of my medical rotation, I felt prepared for leading my own ward rounds without a more senior doctor present. And as you can see here, 90% of the respondents either disagreed or strongly disagreed with this statement. So as you can tell, the vast majority didn't feel confident when they first started their rotation. We asked them about the frequency with the question, during your medical rotation in F1, on average, how often did you lead your own ward round, i.e. do a ward round without a more senior doctor present? And as you can see here, 84% of the respondents said that they were doing this twice a week or more often on their medical rotation. So it was clearly happening regularly in the trust. Next, we asked them about how often they considered a number of important aspects, which you can see along the bottom here, and which form part of the checklist that we later implemented, and there's a couple of them to pass around if you want to have a look. And we asked them to rate it on a scale from always, which you can see in green here, through to red, which you can see represents very rarely. And the key findings really, although this is obviously a lot of data to take in and it's quite difficult to interpret, essentially the things that we think make up sort of the core components of a ward round, reviewing the observations and recent investigation results, taking a focused history and examination, addressing patient concerns and reviewing their medications, the vast majority said that they were doing that either always or frequently. But obviously with the other findings there's much more variability, and it may or may not be that that's appropriate depending on the patient in front of you, because you don't always have to think about everything every time with every patient. But as you can see, the things that are considered less often are still very important things like nutrition, mobility, VTE prophylaxis, C-lymph care and discharge planning. Finally, we asked them how helpful they thought 3 interventions would be, and these were 3 interventions that we just wrapped together off the top of our heads from discussion with colleagues. One was an A4 sheet with some guidance about delivering ward rounds. One was a credit card sized aid memoir. And we said credit card size because we'd had an antibiotic policy that was credit card size to put on the back of your name badge, and it was really easy and accessible, and a lot of people found it really helpful. And finally, a brief teaching session. And the percentages that you see here are the percentage that found each intervention that they thought it would be either useful or extremely useful. And we thought that the 79% for the credit card sized aid memoir and the 84% for the brief teaching session would make those worth trying. Finally, we gave them the opportunity to give any free text comments, and we did have 4 people that left comments, which we're not going to go through in detail, but they were in 2 main areas. One was the infrequency of senior-led ward rounds and the appropriateness of that, and the other were a couple of thoughts and suggestions for improvements. Okay, so what did we do in response to this? So we made the aid memoir, which you can see here, in conjunction with Dr. Ian McNeil, with some support from our supervisor at the time, Dr. Mysore. And we distributed this as a credit card size version to all of the F1s that started in the following year, which was 2015, in August. And we also printed out A4 versions and put it on the ward round trolleys on all of the wards in the trust. Excuse me. Also, Melody had the opportunity to give them a 30-minute session in their induction, just to give them sort of a few hints and tips about life as an F1, and she used 5 of those minutes to tell them about the checklist, why we developed it, and how they might use it in clinical practice. We really wanted to deliver a teaching session. It was the most popular answer, but unfortunately we weren't able to get a slot to do this at the start when it would have been most helpful. We have designed something, and we do hope to deliver it in August of this year.
Okay, so moving on to discussions now. So we recognise that our sample size is small within one trust and perhaps limits our external validity. However, we feel that we have a fairly good response rate, one, due to a fairly successful recruitment process, but more importantly, it means that it gives our results some internal validity. We also acknowledge that there is a potential for bias, so respondent and also recall bias. Some of the F1s that we were surveying in June had actually undertaken their medical rotation between the months of August and December. What we know from our results is that training and mental support is required. What we don't know is actually current practice and the implications for patient care. As we've discussed, we implemented an aid memoir, a prompt. But what we know is that ward rounds are often subject to interruptions, time pressures, and actually this may hinder the use of the aid memoir. We also know that patients, as we alluded to earlier, are different and they all have different needs. So again, it's up to the F1 using the aid memoir to use it appropriately. And part of the reason we called it an aid memoir, as well as what Melody said earlier, was that it suggests it's a prompt rather than a checklist which suggests these are aspects you must consider and must tick off. So what do we do with the results that we found? So it was important for us to disseminate them, particularly to the board of directors at the trust, so that they could become aware of what F1s were doing and how well they were doing it. And as we mentioned, we put in an intervention. What we need to do now is find out, was that intervention effective? So we need to particularly look at utilisation and usefulness of this. And so we plan to resurvey the Scunthorpe and Grimsby F1s in May. We also need to look at further interventions. So as we've already mentioned, the teaching session was regarded as quite popular. So we need to look and see if we can put this in place for the next induction of F1s. And of course, there's always room for further study. So within the white space questions, out of those 4 respondents, many of them commented on the appropriateness of F1s leading ward rounds without senior support. And this should be looked into. Does this occur in other hospitals? How frequently is this occurring? Also, the RCP document that we mentioned earlier in the presentation was focused on senior doctors leading ward rounds, and I think it or we think that it would be worth looking at senior doctors as well to see exactly how they're leading their ward rounds and what's being done. So, in conclusion, so to our study, so the F1s in the Northern Lincolnshire and Gaul NHS Trust felt underprepared for leading their own ward rounds, but were frequently doing so, found that better support and training is required, and we hope this will help to lead a safe, systematic and thorough ward round. And in order to aid this, we've distributed an aid memoir and plan to resurvey to find out the results in a couple of months' time. So just want to acknowledge the two consultants that helped us within the Trust, and obviously the Trust itself for letting us do the research, the references that we used. And so fine, thank you very much for taking the time to listen to us, and happy to take any questions.
Thank you. Right. Catherine first.
In primary care, we use computers all the time, and we use templates a lot. So do you think if you were keeping records on a computer and working with a template, that would be the way forward?
I think this is so controversial. It's a really interesting suggestion, and it's obviously one way to make sure all of the boxes are ticked. But even just with the aid memoir, I could see sort of heads shaking in the room saying, we don't want it to be so subscriptive. So it might be helpful, and that might be one thing to implement, but I think there would be a lot of resistance if we
do
did
have to
something
remember
like
that most of the time the templates aren't completed unless they're done by practice nurses, because doctors are useless at
And just behind you, Andrew.
I was just wondering if it would be, I suppose what we say we do and what we actually do is probably different. And it would be quite easy to go onto an elderly ward, wouldn't it, and get the paper notes and see what the F1's done and what they've actually written. And because I know mine were obstable, plan, continue, because I didn't feel like competent to do anything else. And I don't know if I ever thought about nutrition or VT, and certainly not ceiling of care.
Yeah, absolutely, and there's no way of knowing whether what they told us is the truth, but it was just the easiest way to get the information at the time.
Right, we've got so many questions. We're going to start from the back first. Yes?
I just wondered, I was asked many years ago, when you did your ward round, did you have a senior nurse with you?
No, but that's one of the things that they were quite interested to bring in.
I was very dependent as a
Yes.
She used to keep me right. Especially in what the consultants would like.
Yeah. As you might imagine, when we presented this to the board of directors, they were actually quite shocked and quite far removed from what was happening on the ground, and from the fact that these were being conducted multiple times per week by foundation year doctors. And that was one of the areas suggested in terms of getting it done in conjunction with a sister or a member of ward staff. But I think often that's quite limited in real life by the feasibility of that, by having busy staff around. And one of the things that we discussed anecdotally as well was, do foundation year 1 doctor-led ward rounds last longer as well than seniors ward rounds might? And again, would that have an impact on restricting nurses' ability to continue with other tasks they have to do as well?
It's Anna. Is that Anna? Yeah.
I was just going to say that I remember when I was an F1 at the very beginning, when I start placement, I felt the same as you, nervous about conducting the ward round. As much as I felt nervous about doing lots of other things as well. But in retrospect now, I think that was probably, once I got over the initial fear of maybe doing the first couple, it was my most valuable learning experience. And by the end of it, it was allowed me to collaborate with my colleagues, and if I was stuck on something, you could quite easily phone your registrar or what have you. Do you think perhaps by doing, what sort of other detrimental consequences could there be from this in terms of maybe people not learning as much if they're not allowed to go out and do stuff?
Yeah. Do you mean if we were to suggest that F1s didn't lead ward rounds?
Never did a ward round by themselves.
Yeah, we're not necessarily suggesting that. We're just saying it's a thing that's been mentioned in the free text comments. But I definitely see your point. it's a really good learning experience for people. But I think the thing that we've identified is that when they first start their rotation, they're really thrown in at the deep end, and it'd be good if they could get some support or some sort of guidance, because it's such a huge part of what's done on the wards, and it's fascinating that there's no training on it.
Ian and Amjit, next.
I would just like to congratulate you on a fantastic bit of work. To be thrown in at the deep end, as it sounds like you were in Scunthorpe, and to come up with this solution. I think checklists are here to stay. I think medicine needs to embrace them. And far from reducing the learning experience, I think it increases the learning experience because you don't miss something out. And if you go to any hospital, any ward, you'll find probably around 20% of them have not had their VTE assessed. There are essential things that have not been done. And if a checklist was in place and being used, which I think we need to do like they do in the airline industry, then we would not be in that position.
And is that your question then?
That's my question.
That's a question. I've actually, just to compensate for Ian, I've got 3 questions. The first is, to what extent do you think this is a failure of the Hull York medical system, medical school in training you? Secondly, to what extent is this due to the selection of those who go to your hospital? And thirdly, does it matter if the consultant is going to do a ward round anyway?
Well, interestingly, we did actually look at, because both Jessica and myself went to Hull York Medical School. And
I know.
And we did actually look at the GMC requirements for what should be taught in medical school, and it is not a requirement that graduating doctors should be able to conduct ward rounds, and that is where part of the mismatch is. And one of the limitations of our study, as Serena mentioned, is we only have the information for this trust, and we don't know if it is the same in other trusts, and we'd like to expand to find that out later, so we can't really answer your second question at this stage. And I've forgotten what your third question is, so hopefully...
The third question was, does it matter, given that the consultant is doing a proper ward round anyway?
Well, I think the patient's situation is very fluid, isn't it? And a patient's physical health can change in a matter of minutes, hours, or even a day. So having a consultant-led ward round twice a week for a complex medical patient with multiple comorbidities and a deteriorating medical condition, actually it does matter that they're regularly reviewed. And if it was your loved one in hospital, you'd want them to be being reviewed regularly so that they could receive the highest possible care.
Good answer. This is definitely the last question. Is it a question?
Yeah, it's a question. Do you think all doctors that lead ward rounds should use an aid memoir like this? Not just because that's not practice.
I think it could be valuable to some degree to most people, but I think we would struggle to get them to take it on board. There's just so much resistance, and I think a lot of people will think, well, I don't need it. But at least if we can help the people that are willing to take it on board, then...
It would give a common structure, wouldn't it? Yeah. So that you, as F1s, if you did that with a consultant, and then you do it with yourself, the same thing.
And I think as well, you might be considering those things, but not documenting them. And to you, that might be fine, but then someone else that comes along on call, if you've not said whether or not this patient's having fluids and how much fluids you want to be giving them and all that sort of thing, you're making the job very difficult for your colleagues. So I think that's another way that it could potentially be valuable as well.
Thank you very much. We're going to have a very, very short break, so please stay here while those who've done the marking, we're just going to be hopefully just a couple of minutes. So we'll just nip out for a second. Well, it was incredibly difficult because the people who assessed of the 29 who would present were brilliant because you were all so good. So if you haven't won, it doesn't mean that you work fantastic, and you can put it all in your CVs and get the certificates. So the one that came out slightly on top of all the others, but they were all brilliant, was Anna Winfield and Sophia Ah.
Oh, yeah, Sophia, that's right.
And Sophia. So congratulations. Now, and you get a prize that goes into your bank account, I think. Well done.
Thank you very much.
And would the others all like to come up to receive their certificates? The first is Yazan. So, oh, Saiful, no, he's ill, or she. Daniel. And Jessica and her team. There's a... We've only got 2 still. I'm sure you can get one. If you just ring them, you can get another one.
Need a checklist for that.
Checklist. Okay, now we need to conclude the meeting because I think there was talk in one of the presentations about the need for fluids and food to be assessed. And I've assessed it and it's necessary on my checklist fairly soon, so I'll be very brief. I mean, wasn't that wonderful? I think another round of applause.